So thank you, guys. That was a wonderful introduction. Thank you, and I really appreciate the perspectives. My question is, you're king for the day. I want you to tell me what you know of that works. It's overwhelming, the issues. And I want to make sure those jewels from your lens of where you are and all you've dealt with in your own paths, any health literate health care that you're aware of, Paul, you know exactly what that means. But let's make sure we get on the table examples of strategies, practices, approaches that work so they don't get lost in the overwhelming burden of all the issues. Hi, I'm Ruth. Parker.
I have to say, I feel like I have my scientific advisory board in the front row, people who helped advise me in planning our Somali study, including Ruth. But, you know, I'm going to talk more so from my perspective as a pediatrician. After going to one of Michael Pashorlo's health literacy research conferences, I heard a great presentation by a pediatrician from North Carolina who was working in a huge Kaiser Permanente-like health system there. I forget what they were called, but she had done a project looking at the information that pediatricians will give out to families, you know, when kids are having their checkups. And their community, I think, was largely African American and Latino and low literate, low income. And she concluded that she needed to have written materials that were very basic, kind of bullet point, bulleted, you know, take-home message. You know, no more than like 3 to 5 key points, single line, bulleted lists, basically. And I came back to Massachusetts with that approach. At the practice where I was working, where I already mentioned I had patients from over 50 countries from around the world, from a variety of legal statuses and a variety of socioeconomic statuses and a variety of ethnic and religious backgrounds. And I decided to update our parent information sheets, which were horribly out of date. And so I took the American Academy of Pediatrics standard forms, which were very detailed, lots of information, very dense, small fonts, hard to read. This was all in English, by the way, because it's impossible to provide written materials in a standardized way to people from over 50 countries around the world. So then I had our existing ones, and then I had created this kind of a simple bulleted list one of the key points that I thought were most relevant. And interestingly enough, the families whose first language was not English, they hated that. They didn't want it. They actually loved the American Academy of Pediatrics forms because of the density of information. They wanted the information and they liked it in writing, but it was too complicated for them and they didn't like the format. So we went and created our own that was more like what we previously had, but with additional information from the American Academy of Pediatrics' forms, but we created it in a way that was relatively easy to read, big fonts, bulleted kind of list formats, and you know, it worked. We got great feedback on them, and you know, even if people couldn't read them themselves, they had friends and families who could read them for them. And again, this gets to my point about the importance of community and families, and it worked. And it was a way that we could provide information to everybody. We did translate them into our most common languages in our clinic, which were Brazilian, Portuguese, Spanish, Haitian Creole. You know, but we couldn't do them for everybody. The resources were limited. I had to get a grant, a $20,000 grant to pay for all of that, you know, to translate 15 5 to 7 page documents into 3 languages. That's a lot of translation time that we had to pay for. And the Cambridge Health Alliance came through and gave us grant money to do that. But, you know, that desire for information, I think, is universal regardless of people's literacy levels. And if you can find a way to provide it to people, this was a local solution for us in Massachusetts and may not work in other communities, but that's the kind of approach that I think you have to take, is figuring out what your needs are in your community, what people want, and then a way to deliver it to them effectively.
I'm Katina O'Leary. I'm from Health Literacy Media in St. Louis, Missouri. We're not the people saying ugly things to you today. It was not us, I'm sure. But, you know, I was interested to hear you talk about the words you use and data and what you collect and how and why. And you mentioned proxies and thinking about proxies for these questions that we're not asking otherwise. And I just wondered if you could say more about the kinds of questions that you came up with as the proxies to help inform what we do and why we do it.
The proxy references that I had made, I think you can have a lot more detailed discussion with the Oregon primary care representatives specifically, but on a higher level, for example, as I shared, health centers have historically never asked, are you foreign born? And because of the limited data at the state and local levels, particularly around the country for Asian Americans, Pacific Islanders, we've always had very poor demographic information in many areas that we are trying to articulate get that information for. And for so long, we used to use undocumented as a proxy, for example. But since data collection has improved over the years, my understanding now is that we are looking at primary preferred language and race and ethnicity in combination as a more accurate proxy for foreign born than just collecting undocumented information like we used to in the 90s. But I believe the representative from Oregon can be more specific with regards to what are the specific questions that are actually being asked within the survey tool itself. I don't know it specifically. Yeah. Does that answer?
I think that's really helpful, and worried that you can say more.
Okay.
Ernestine Willis, pediatrician at the Medical College of Wisconsin. I wanted to follow up with Ruth's question a little bit more, because while I respect what you're doing, Dr. Gebman, in Cambridge, I'm trying to appreciate that you have some other challenges that you have to think about overcoming. The fear with the immigrant refugee population, the mistrust, trustfulness among other marginalized populations. And I wanted to know, have you found that you can get data to really translate into overcoming that challenge? And does that translate into sustainable, effective community capacity building? Did you follow my question?
I think I did, and we'll see if you can cut me off if my answer doesn't seem to be getting at what you had in mind. I have to be honest, you know, living in Massachusetts and having practiced in Cambridge, Massachusetts for the past 11 years, a little bit of a bubble, you know, because we're very sensitive to these issues and we try to go out of our way to do this, and the state has regulations around community health needs assessments and things like that that the nonprofit sector has to do, because our public health system is very centralized in much of the Northeast, and Massachusetts is a key example of this. We don't have sort of the county structure that elsewhere in the country relies on for public services, including public health. So the concept of the county health department and the public health clinic doesn't exist in New England for the most part. So our nonprofit sector provides a lot of these basic services under contracts with the state. So the community health centers do that. Large safety net health systems like Cambridge Health Alliance do that, and they have to do these community needs assessments. Now in Cambridge also, it has the unique structure of having been also the public hospital, the Cambridge City Hospital originally, and the Cambridge Health Department. So even though it's a private nonprofit, the city of Cambridge still has a stake in it, and it runs the public health department for the city of Cambridge, and has close relationships with the health departments in the other towns where we have a clinical presence. So it's also, that may be a bubble, but it's also an example of how an institution and the people like me who work there can create relationships with community organizations. We have you know, parent advisory boards now. I can't say we because I don't work there anymore. They have parent advisory boards at the clinic level, at the institutional level, or patient advisory boards for the non-pediatric population. And they have relationships. Representatives from the community sit on various boards, the hospital boards, board of directors. There are all sorts of committee, like community outreach type committees that exist that come down from the board of directors. And so this permeates through the institutional structure, and the people who work there are committed to having these kinds of relationships as well. That they attract the type of person to work there who wants to be engaged in the community and get involved. And the pediatrics department was perhaps exceptional with that over the years, led by a doctor named David Link, who was our chief of pediatrics for probably about 35 years. And so when you have that kind of experience, starting as he did as the sort of hole-in-the-wall city hospital pediatric well baby clinic for the, you know, the uninsured population back then, that creates a lot of relationships with the community, with the schools, with the social service providers, with parent groups, and those relationships, you know, build over time, and the institution then took on a lot of that as well when Cambridge Health Alliance was formed about 15 years ago. So a lot of it may come from individuals who desire to have the relationships with the community around special projects or grants or research or what have you, but it also starts at the institutional level, that the institution has to have the structure and the commitment to engage people from the community. And in Massachusetts, we frequently have that. I can't speak to even elsewhere in the state necessarily, but in the greater Boston area, there's this very strong connection. Our community health center scene goes back to the early 1970s, late 1960s. You know, the city of Boston, in fact, once you get outside the academic medical centers, we don't have a lot of private practices in the city of Boston because of the role of the community health centers. You know, a lot of private medical practitioners left the city in the 60s and early 70s, and that void was filled by the community health centers. And so the strength of that means that there are these strong community involvement with the healthcare delivery infrastructure, at least in the greater Boston, eastern Massachusetts area. So we get to that that level of trust. People know that the institutions support them, and they know there's people like me who've worked a lot with immigrant advocacy groups and community groups who are at these institutions.
And you know, it's not so much, I think, it's not so much a clinical answer as much as what you were talking about towards the end there. I mean, in my heart of hearts, I think the majority of people in this country think the way we do. It's just, I think right now the discussion is being dominated by a smaller group. That's creating a lot of fear amongst others, and they're deciding, well, what do I do? Do I stay silent or do I not? And when you put it in a political context, I mean, you can see it in Washington right now with the new Health Care Act. You know, there's one party right now is even starting to think, well, I don't know, is there peril in me moving forward with voting on this change? So even they're pushing the pause button. But why are they pushing the pause button? Because people are pushing back. You know, they're at their community meetings and they're saying, hey, wait a minute, time out. So they're pausing. So, you know, I mentioned earlier when an elected official, you know, the basis by which they make a decision when they're sitting on that dais, By the same token, in my experience, I think the effective elected official operates on a three-pronged stool. Okay, first is you have an issue. So what do? You have to thoroughly and completely understand your issue. Well, how do you do that? You do your homework, and you surround yourself with those professionals who validate the information that you have so that you are fully equipped and ready to go once that debate begins. That's the first leg. The second leg is the community. You know, you have to have the community stakeholders engaged and in place and ready to, quote, march on City Hall when the time is right. And the third leg is the media. Okay, you have to know how and when to use the media, including our social media. Extremely effective. You have those three pieces moving at the same time. I'm not saying you're going to win every time, but for sure you're going to fight a heck of a battle. And number two, the odds are high you're going to win. You know, and I've used this, you know, in all of my career, and I find it's extremely effective. So when you look at the money, you know, and I'm making a big assumption here. You correct me if I'm wrong, but I know there's a lot of great foundations around this country that provide money for different activities, but they can't provide it all. So I think for the most part, people come back on the state, the federal government, county governments to provide the lion's share of monies for what we do. And I go back to what I said early on. You know, you have 5 to 7 people every Tuesday or whatever day those boards meet, and they're making huge decisions. There's punching those buttons on big amounts of dollars, which is why if we understand how to connect those three pieces all the time and move forward, you can get things done. You know, and not to say not without peril. You know, when we were able to pull off that $5 million, you know, for the specialized health care for the undocks, trust me, that was not without political risk. But, you know, because there were folks in there that still weren't happy, even today, with the decision that, quote, I moved $5 million to provide care for undocumented. But you know what? Not that I needed it, but the cover was there because the community was there. And for those other electeds who may have had, which way should I go on this? Well, the cover was there for them too. So, you know, it works in various ways for different reasons. But electeds need cover. You're just like right now those guys in Washington. They're looking for cover. So the more we stay engaged, I think the more, doctor, you know, whatever issue you may be dealing with, if you're doing it by yourself on a clearly clinical level and you're right 150%, doesn't mean anything. If you don't have the folks behind you giving you the support that you need to get things done. And that's just the way it works, and that's the way electeds look out when you're talking about an issue that's important to you. If you're not fully engaged with all the right partners, and the media is powerful. You know, you've all seen it at different levels. If they're with you to the end, and that's very powerful in and of itself.
I know a few candidates in the last election that could have benefited by that advice. I'm going to ask you to give the microphone both to Rob and then to Jennifer, and then I'm going to open it up to the larger audience. Rob?
There's Rob. Okay. And then you can just please identify yourself for the transcriptionist who's watching on the web. And then if you'll pass it to Jennifer.
Rob Logan, National Library of Medicine. Because I'm the first federal official who's spoken, okay, I need to say something that probably is controversial but needs to be said. Immigration enforcement is not unique to the current administration. And I think that's important to be said. I realize maybe the tone has changed, but there was enforcement going back a number of years. And if you look at the data of the last administration, it speaks for itself, let's put it that way. My question is, the last time the roundtable met, we heard from a number of people who combine medical care and social welfare care together, okay? And they made a very compelling, strong argument that the way to help for the future for indigent care in the United States and the way forward to help with the people who are marginalized is to have a healthcare system where those things are combined, okay? Curious about your response to that idea.
No, I'm excited about that question. One of the biggest strengths of our social determinant tool, which is called PREPARE, by the way, and it's a long acronym, and I'm sorry, I can't say, I don't know what it is. off the top of my head, but it's called Prepare. But it's our social determinant needs assessment tool. It really was part of APCHO's aspirations to be able to help strengthen the relationships of our community health centers and other social service organizations. Meaning, as I said earlier, the tool identifies the social needs of the patients that are being served. And the health centers do have these enabling services that help address all of that. But they are also starting to identify other social service areas that they don't have services for. And so this tool provides them a systematic way of being able to identify what are those other social factors that are prevalent within their patient population. And they can prioritize that any way they want, such as, you know, what are the social factors most common among their most expensive patients, or their, you know, most complex patients, or their most hard to control diabetes patients. They're able to identify it systematically and either develop the services themselves or develop the community partnerships that they need to be able to address those social factors in combination with the health services that they provide for those patients.
Now can you hear me? Okay, good. I'm Jennifer Dillahay, and I'm with the Arkansas Department of Health. And in Arkansas, we have a large population of Pacific Islanders. They're not immigrants, and they're not refugees. They're migrants, and they're legally, but they're not eligible for Medicaid. And so they do have a difficult time navigating health care, obtaining what they need, and so forth. And there's important language and cultural barriers as well. My observation is that the faith-based community of those Pacific Islanders would be an important way to bridge the health literacy gap for people accessing the care they need, the social services they need, and so forth, that their faith-based organizations, particularly their faith community-based networks, would be really valuable. But we have difficulty connecting that in our state, and I'm thinking it's not that uncommon. And so I would like to solicit your ideas for how working with faith-based organizations and other community-based organizations can help public health and the health system bridge that health literacy gap for the people they serve.
I was actually, I feel like I'm taking the microphone somewhere. I was actually in Arkansas just last year for a Pacific Islander Health Summit. And I actually co-presented on health disparity issues with a public health nurse. And first things that she told me that she said was the smartest thing that they did was that they set up a public health tuberculosis clinic across the hall from the community health center, so that they can coordinate all of their efforts for their TB control program with the community health center staff. So that was, I was just sharing her comment. But with regards to your point about faith-based groups, one of the things that was unique with the partnerships that we established for the enrollment efforts, as I shared, there were 72 different community organizations. And some did utilize faith-based approaches for the outreach to their specific communities. But we really left it to each of our local community partners to identify what were the most effective strategies, because they know their community best. And we didn't prescribe what strategies or tactics. We just provided the resources and materials and the technical assistance that they needed, but we utilized their knowledge of their community to get to them and get that enrollment information to them. I don't have more specific knowledge or that I can share about developing relationships or which communities faith-based efforts are most effective for. My recommendation is really to develop those relationships with the community groups that serve the communities that are of interest, and through those relationships, you'll learn which strategies and approaches would be most effective.
I'd like to just add to that quickly. You know, from our research with the Somali community in Massachusetts, I mentioned that the Somalis tend to be a fairly insular community, at least in our part of the country, and very devout in their practice of the Islamic faith. And one of the things we found out through a combination of factors, one was some information we gathered through the study, and the other was just observation in one of these MAA groups that I mentioned earlier that worked with the Somali community, which was next door to a small mosque, that the floor in their bathroom was rotting because it was constantly getting wet because people would come over from the mosque to do their pre-prayer ablution, their washing and cleanliness and personal hygiene. And so we realized from some of the feedback that some people were including toothbrushing or using a stick brush to clean their teeth prior to prayer, and that if we wanted to promote oral hygiene practices in the Somali community, a logical way to do that was to work with the imam and the mosque to encourage them to include it, encourage the congregation to include it in their pre-prayer ablution. And so this was sort of an idea around social marketing using the faith-based approach because it worked for the Somali community. We knew it would work. There were people who were already doing it and had said as much to us. So in terms of being a best practice that we could essentially verify from our research and promote, I think that's a great role for a faith-based organization. I'm not a big fan of just saying, well, this community goes to church or temple or the mosque, and therefore we should use that for a public health agenda. There's no evidence to suggest that that's going to be better than any other approach unless you really know have a specific targeted practice that you're trying to promote and have access to that community for in a very culturally appropriate manner.
I did promise questions from the audience. Thanks very much for those very acute responses. Any questions from the audience, not the panel members? Okay, we're just about ready to go for a break, so I'll take one more question from the round table. And Lori?
Are you going to warn me not to have a long question? Yeah, I thought so. And I'm Lori Francis from the Oregon Primary Care Association. We work with federally qualified health centers also and work with Jeff actively. So I just want to quickly, very quick preamble. Health centers were started as centers of community health. They were about upstream issues. They were about equity, education, legal assistance, all those things that we are now have come around, I think, in health literacy to figure out how we disentangle a history of paying for medical care in health centers when they were really truly about social issues and economic issues in the beginning, including in Boston. And so my comments to you guys are questions, really. I love the panel, by the way. Thank you so much. It's such a great combination of all of these issues and how we bring our understanding of health care and its inadequacy in improving health outcomes to sort of issues of social justice and power and advocacy. And one of the things that Jeff's referencing, the PREPARE tool, I'll tell you what it stands for. This is kind of like Rachel Maddow. It stands for Protocol for Responding to and Assessing Patient Assets, risks and experiences. And I'm happy to share that with anybody if you want to bring the, yeah, it's hard to remember. How we take our understanding of social and economic drivers to health and well-being in the healthcare arena and pull them into aligned power and voices. And I think Prepare has that opportunity to connect. So how do we do that?
Well, I can start that one off, I think, because I started my career working in community health centers in Boston, first one in the Dorchester neighborhood, then one in Roxbury. And early in my career, when I was a fellow, I teamed up with a group which is now called the Right Question Institute, which was working in educational settings, trying to empower parents to advocate for their children. You know, the educational system in Boston came out of a very tumultuous era with racial segregation and the riots in the 60s and 70s. And for a long time afterwards, there was still a lot of segregation in the schools despite busing, and the schools kind of fell apart. And there was this real need and role for parents to get involved and engaged. And over the decades since then, this has been applied. I worked with them the first time they applied their strategy around parent activism and advocacy in a healthcare setting. So it was teaching parents of children to advocate for their kids in the healthcare world, to ask questions. It gets to these concepts in health literacy that came out like these Ask Me 3 approaches. So this was empowering parents and patients to be active and engaged in their health care, and they were really pioneering in this respect. And now this is with the advent of health literacy as sort of an academic field, this comes into play in concepts like patient activation and having patient navigators or community navigators. And it gets to the idea of how can you get around the barriers of literacy and language, and one of the ways is to work with people to teach them how to advocate for themselves, even if they don't have the literacy skills. And there are different ways to do that, different tools to do that, but teaching people to be engaged and active and how to do it effectively by asking questions. You know, it's a skill that you have to learn, and it's a culturally specific skill too. And that's what this group that I worked with does, the Right Question Institute, is they teach people how to get parents, patients, whomever, engaged and active in their own care as equal participants. And this nowadays sounds like old hat when you talk about patient-centered medical homes, but it's a relatively new concept in medicine, and it's critically important.
Thank you, Paul. And once again, thank Alicia for the panel moderator, and thank the panel. This has been an exceptionally good panel. Rima, I owe you one for the next question round. Anyway, we have a 15-minute break, and we'll be back in 15 minutes to resume the next panel discussion. Thank you.